Hello everyone. So in this lecture series we'll be learning about ectopic pregnancy. So what do you mean by ectopic pregnancy? So remember, whenever there is an implantation, that implantation should occur, okay, that implantation should occur in the fundus of the uterus over here. Now anyways, if the implantation occurs in the fallopian tube, and more specifically in different parts of the fallopian tube, it might be either in the fimbriated end, it might be either in the ampulla, it might be either in the isthmus, or it can be either in the interstitium, it can be then in the infundibulum. Anywhere if there's an implantation, that is known as ectopic pregnancy. Not only the fallopian tube, it might get implanted in the ovaries, it might get implanted in the cervix, it might get implanted in the abdomen. Okay, so these are the different sites where there's an implantation, and that will be termed as an ectopic pregnancy. So moreover, the more common is the fallopian tube. Okay, the fallopian tube, and in the fallopian tube, which is the most common site for implantation, that is actually the ampulla, because ampulla is somewhere where there is stasis of the ova for fertilization. For the sake of fertilization, there's some stasis, and that particular area, as soon as the fertilization occurs, there's an implantation that is termed as an ectopic pregnancy. Clear? Now, what is the most important diagnostic marker for ectopic pregnancy? I'll just concise all the points that we often do, and then we'll talk about the basics. Okay, so the most important investigation marker would be USG. Anyone says you what is the most important marker? That is USG or transvaginal sonography. Okay, so but we need to know about something about the pathology, something about the risk factors. So what are the risk factors for an implantation in the fallopian tube? So there are different risk factors for the implantation, but the most common one being the past history. Okay, so if there's a past history of ectopic pregnancy in a female, then she carries a high-fold risk, she carries a higher chances for having implantation again at that particular site. Next one would be smoking. So remember, in smoking, what you need to remember is there's certain cells in these fallopian tube known as the cannabinoid receptors, and these cannabinoid receptors are the ones that that affect the motility of the fallopian tube. Now, if there is by any way, if the female is a smoker, then that cannabinoid receptor is affected, and the motility of the tube decreases. The tube motility, it decreases. As the tube motility decreases, it will lead to an implantation at the site where it should not be implanted. Number 3 would be pelvic inflammatory disease, and most common pelvic inflammatory disease caused is known as chlamydia. Remember, tuberculosis of the tube is the second most common. So for the first one is the chlamydia, and the second one will be the tuberculosis of the fallopian tube. So by anyways, there's chlamydia or tuberculosis. What happens is there's something which is known as actually this interstitial cells of Kagel. Okay, Kagel. Now you have listened to this interstitial cells of Kagel in your neuro, in your GIT, but here also there's something which is known as interstitial cells of Kagel. Sorry, which tends to be affected by chlamydia. Okay, these are actually the pacemaker cells that tends to initiate the motility. And remember, excess of progesterone is also one of the most common risk factor. Excess of progesterone. So what happens when there's an excess of progesterone? When there's an excess of progesterone, we know that the progesterone are smooth muscle relaxants. So when there is an excess of progesterone, that will lead to relaxation of the fallopian tube, decrease in the motility, that will lead to implantation of the ova in the ectopic sites. Okay. Now remember, the tubal ectopic is 96%, ovarian 3%, and other one is 1%. In the cervical, in the abdominal, in the previous cesarean scar, and implantation in the previous cesarean scar is less than 1%. Okay, less than 1% in both the ones. Okay, less than 1% cervical, less than 1% in the previous cesarean scar. 96% of the implantation occurs in the fallopian tube, 3% in the ovary, 1% in the abdomen. Okay, so these are the incidence of the these are the percentile distribution of the ectopic pregnancy that occurs in the different reproductive sites of a female. Okay, next, very, very important that you need to remember is the incidence. So incidence of ectopic pregnancy, it is 1 in 150 or 1 in 300. Okay, now remember this is very, very important. Now, next thing that you need to remember is the increase in the maternal age. Of course, increase in the maternal age is very, very common risk factor for all the anomalies that occurs. Now you need to know about the ectopic triad. Okay, ectopic triad. Now, what do you mean by ectopic triad? See, ectopic triad. See, whenever there's a pregnancy, what would the female first present with? Of course, you have already gone through the postings. You have already learned about amenorrhea. So she will present with amenorrhea. Okay, she will present with amenorrhea. She will present with PV bleeding. She will present with PV bleeding, but this PV bleeding will not be that much as that of abortion also. Because whenever we talk about abortion, we are talking about the intrauterine implantation of the fetus, of the product of the conception, and that product of conception is present in the intrauterine site. Remember one very, very, very important thing, that is, whenever something is in the intrauterine site, it tends to act in such a way that the estrogen and progesterone also releases in regards to the implantation that has occurred in the intrauterine site. For example, the implantation has occurred now in the fallopian tube in the case of ectopic pregnancy. Then what will happen is that there is a release of estrogen and progesterone, okay, but not as that of the one that is in regards to the implantation of the fetus in the intrauterine site. Okay, let me make it more simple. Suppose this is your uterus. There's an implantation over here. Okay, of course there will be thickening. So when there will be thickening, then this thickening on regards to this intrauterine will be much more higher than the thickening that occurs when there's an ectopic pregnancy. Suppose implantation is over here in the fallopian tube, and the thickness will be a bit low. That's why the PV bleeding that you see is slightly less than the abortion, or quite a lot less. It is less. Okay. And the next thing that you'll see is the pain in the abdomen, because this pain in the abdomen can occur at any site of. It's because of actually contractions. Okay, this pain in the abdomen is always because of contractions. Okay, let's go to the diagnostic marker. So whenever we talk about the diagnostic marker, always we go with TVS or USG. So in the TVS or USG, what you'll see is, you'll see this like this, and you'll see this over here like this. So this area is an anechoic area. Okay, and this area is slightly hyperechoic. That means it is slightly blackish than the surrounding very, very black structure. Okay, these are very, very black, and this is slightly a bit black. Okay, a bit black. That is known as a hyperechoic area. Now, if this is the thing that you see in your USG, then that refers to a gestational sac. Now, this gestational sac, inside this anechoic area, very blackish area, you can see the yolk sac, and you can see the embryo also. Okay, sometimes. Now, this gestational sac is actually a true sac. Now, this gestational sac may be seen at the site of implantation. If it is an intrauterine, you'll see it in intrauterine. If it is an extrauterine, you'll see it in extrauterine. Now, in the case of implantation of the product of conception, product of fertilization is in the fallopian tube. Now, what will happen is, here you'll see the true sac in the fallopian tube. What will you see in the ovary? In the endometrium. In the endometrium, you will see a pseudosac. In the endometrium, you will see a pseudosac is something like this. It's like a slit-like opening over here, and then there's this whitish line, and then you have this blackish structure. Okay, like this. This is actually the pseudosac. And pseudosac, it does not consist of yolk sac. It doesn't consist of this one. And remember, it should increase, this true sac should increase by 1 millimeter per day. Okay, that is very, very important. The serum progesterone should actually, normally for the viable intrauterine pregnancy, should be more than 10 nanogram per milliliter. Okay, if it is more than 5 nanogram per milliliter, it is a viable, and if it is less than 5 nanogram per milliliter, it is non-viable. So moreover, the progesterone level will be in between 5 to 10. Okay, in the case of ectopic pregnancy. But the most commonly done investigation is of course this one. If this one fails, if the radiologist they can't look into this gestational sac or the pseudo sac well properly, and there's a biased result, what we can do is we can go for serum HCG. Normally the serum HCG it tends to double in 48 hours. Normally the serum HCG it doubles, so but it was X here, it will 2X in the 48 hours. If it doesn't double, if it decrease, then that would be actually a case of your failing intrauterine pregnancy or failing ectopic pregnancy. If it decreases, if it doesn't double, like from X it will be X plus 5, or it might be X plus 6, something like this. Okay, I'm just giving an example. If it does not double, if it doubles, then that is of course intrauterine pregnancy. If it doesn't double, it might be a ectopic growing or a ruptured pregnancy. Ectopic growing or a ruptured pregnancy. Okay, clear? So this was a very short video on ectopic pregnancy. I'll add up with more things in the upcoming video.